Welcome back to the deep dive. Today, we're zeroing in on Mycoplasma pneumonia.
Ah, the cause of many respiratory infections.
Exactly. You probably know it better as walking pneumonia. Sounds kind of mild, doesn't it?
Mm,
But it's really important to understand properly.
definitely.
We've got the revision notes right here, and the plan, as always, is to pull out the absolute must-know stuff for your revision. Quick and effective.
Let's do it. So, Mycoplasma pneumonia, what is it fundamentally? It's a bacterium, a specific pathogen that causes infections in your respiratory tract.
Okay.
And yeah, like you said, it's a really common cause of what we call atypical pneumonia or walking pneumonia.
Right, atypical. So it's bacterial. What kind of bacterium are we talking about? Anything special about it?
There is actually, it belongs to the molecules class. And the really key thing, clinically speaking, is that it doesn't have a cell wall.
No cell wall. Why does that matter?
Well, think about how many antibiotics work. They target the bacterial cell wall. Penicillins, cephalosporins, they won't touch this one.
Ah, okay. That's crucial for treatment choices. And it infects the respiratory tract, you said.
Primarily, yes. That's its main habitat.
So who's most at risk of getting this wall-less wonder?
Good question.
Hmm.
It tends to hit young adults and adolescents most often.
Right, not necessarily the very young or old then.
You can get it, but peak incidence is often in that younger adult group, and environment plays a big role through crowded settings.
Like schools.
Dorms, exactly. Schools, university halls, military barracks, places where close contact is common. That's how it spreads.
Makes sense. Close contact. So how does it actually cause the illness, the cough, and feeling unwell?
Okay, so pathophysiology. It gets
Ah,
into the respiratory tract and attaches to the cells lining your airways, the bronchial tubes, and even down into the alveoli, the air
I
sacs.
said no, that was
It damages those epithelial cells. And your body's response to that damage is inflammation. That inflammation is what causes the symptoms of pneumonia.
Okay, the inflammation is key. Now, if someone comes in coughing, how do you know it's mycoplasma and not, flu or something else?
That's the differential diagnosis challenge. The symptoms can overlap. You absolutely have to consider other things, such as viral pneumonia is a big one, other types of bacterial pneumonia like strep pneumo, even fungal infections sometimes, though they're less common causes of community-acquired pneumonia.
Got it. Need to keep those differentials in mind. How common is this? Is it everywhere?
Epidemiologically, yeah, it's pretty widespread, found all over the world, definitely here in the UK too.
Any particular time of year?
Tends to be a bit more common in late summer and early autumn, but you can see it year-round. And like we said, you often see outbreaks in those crowded settings. Schools are classic for mycoplasma outbreaks.
Okay, so let's talk symptoms. What are the key clinical features you'd look out for?
The absolute hallmark is usually a persistent cough. Often dry, hacking, can linger for weeks.
Weeks. Wow. What else?
Sore throat is common, headache, feeling really wiped out, fatigue, malaise, often a low-grade fever, not usually super high, and maybe some chest discomfort.
And this is the atypical part, right? Generally milder symptoms.
Generally, yes. Compared to a classic pneumococcal pneumonia with sudden high fever, chills, and productive cough, mycoplasma often has a more gradual onset and less severe symptoms. But not always. It can still make people quite unwell.
Okay, milder usually, but needs investigation. How do you actually confirm it's mycoplasma?
The gold standard test nowadays is PCR polymerase chain reaction,
On what kind of sample?
usually a throat swab or sputum, if the patient can produce any. PCR detects the bacterial DNA, so it confirms an active infection. It's very specific and sensitive.
Any other tests?
Serology, looking for antibodies in the blood, can be helpful, especially later in the illness, or to confirm a past infection. But PCR is better for diagnosing acute infection, and a chest x-ray is often done.
What does the x-ray show?
It can vary a lot.
Yeah.
Sometimes it looks surprisingly clear despite the symptoms. Other times you might see patchy infiltrates, often in the lower lobes. It helps assess the severity and rule out other things too.
Right, so you've diagnosed it. How do you treat it? You mentioned the cell wall thing.
Exactly. So penicillin-type antibiotics are out. The mainstays are macrolides like azithromycin or clarithromycin, or tetracyclines like doxycycline.
Which one do you choose?
It depends a bit on the patient, local resistance pattern, severity. Macrolides are often preferred, especially in children where tetracyclines aren't typically used. Doxycycline is a good option for adults.
And is it just antibiotics?
No, supportive care is really important too. Rest, plenty of fluids, maybe something for the fever or cough if needed. Most cases are managed as outpatients.
What's the outlook usually? Do people get better? Okay.
Generally, yes. The prognosis is good for most people. They recover fully, although that cough can sometimes drag on for a bit.
But complications can happen.
They can, yeah,
Mhm.
especially if it's severe or goes untreated, or in people with underlying health
What
issues.
sort of complications should you be aware of?
You can get more severe respiratory problems like worsening pneumonia needing hospitalization, rarely respiratory failure, or fluid around the lung, which is pleural effusion. It can also trigger bronchitis or make asthma worse.
Anything outside the lungs.
Yes, though less common. It can sometimes affect the nervous system, causing things like encephalitis
Hmm.
or the heart myocarditis. And there are some rare but serious immune-related complications like Stevens-Johnson syndrome or hemolytic anemia.
Okay, so mostly good outcomes, but need to watch for those potential issues. This is a lot to remember for exams. Any tips?
Definitely. For the common symptoms, try the mnemonic chest staph.
Chest staff?
Yeah. Cough, headache, exhaustion, fatigue, sore throat, temperature, low grade, and feeling generally unwell, like malaise.
Chest staff. Nice. Any example questions?
Sure. A classic vignette might be a 19-year-old student presents with a 2-week history of persistent dry cough, headache, and feeling tired. They have a low-grade fever. What's a likely organism?
And the answer based on today would be Mycoplasma pneumonia.
Exactly. And for treatment, remember the main antibiotic classes, macrolides and tetracyclines. You could think macrotetra.
Microtetra. Good one. Okay, so let's quickly recap. Mycoplasma pneumonia. It's that bacterium causing atypical or walking pneumonia. Key features are that persistent cough, often dry, plus headache, fatigue, low fever. Remember, it lacks a cell wall.
Right. Diagnosed ideally with PCR. Treated with macrolides like azithromycin or tetracyclines like doxycycline. Prognosis is generally good, but watch for complications.
Perfect summary. And of course, if you are revising for the MSRA and want more practice questions, detailed notes, definitely check out passthemsra.com.
It's a great resource.
And for loads of free MSRA revision materials, don't forget freemsra.com. So understanding common conditions like mycoplasma pneumonia is absolutely fundamental.
Couldn't agree more.
It makes you think, though, what other infections might present in an atypical way, catching you off guard? Something to keep in mind. Thanks for joining us for this deep dive.